Hello, and thank you for joining me today as I go through the defense of my Doctor of Nursing Practice Quality Improvement Project, effects of implementing the critical care pain observation tool on length of intubation. Many people require intubation every year, which can lead to discomfort and various complications. Critically ill patients on mechanical ventilation often experience pain, but due to the endotracheal tube, are unable to communicate their pain effectively. This can result in inadequate management of pain. The mismanagement of pain can lead to increased sedation and negative patient outcomes, such as vital sign changes, prolonged hospitalization, mechanical ventilation, and psychological distress. Current research and guidelines from the Society of Critical Care Medicine recommend addressing pain before even considering adding a sedative agent. However, many intubated patients are sedated first. Around 800,000 people in the United States are placed on a mechanical ventilator every year. There are various reasons why they can end up on a ventilator, such as being involved in a motor vehicle accident, having a stroke, or heart attack. The average length of intubation is about 3 days, but this can vary depending upon why the patient is intubated. Someone who had a minor surgery may only require the ventilator for a few hours, while others may require it for the rest of their lives, such as someone who has sustained a high cervical spine injury. If a patient is not extubated by the first or second day, they are at an increased risk for ventilator-associated events. While mechanical ventilation is necessary, it comes with risks including delirium, muscle atrophy, lung damage, prolonged hospitalizations, and death. In fact, the CDC states that patients who are intubated are at higher risk for poor outcomes, which include barotrauma, pulmonary embolism, pulmonary edema, sepsis, and infection. They also state that the mortality for intubated patients who have an acute lung injury and are over the age of 85 have a 60% chance of mortality. Pain is a prevalent issue for ICU patients. In fact, more than 71% of patients experiencing it. Improper treatment of pain can lead to various complications and increased mortality rates. Pain is subjective and what it is whatever a patient says it is, and it is often referred to as a fifth vital sign. However, those who are intubated may be unable to communicate their pain. For this reason, it must be assessed and treated properly to prevent distress. Distress can result in agitation, which can lead to tachycardia, hypertension, ventilator dyssynchrony, all of which can prompt a healthcare provider to increase the amount of sedation patients are receiving. It's reported that up to 50% of healthcare professionals either overestimate or underestimate their patients' pain intensity due to the use of a non-validated pain assessment tool or due to nursing bias. Untreated pain is associated with both physiologic and psychological stressors, which can worsen medical conditions. Validated pain scales, such as the CPOT, can decrease the incidence and intensity of pain that the patients experience, which in turn can influence the amount of medications and sedatives they receive. The latest 2018 guidelines for managing pain, agitation, sedation, delirium, and sleep distribution in adult ICU patients emphasizes the importance of frequent pain assessments. The CPOT is recommended for patients who are unable to communicate. Using both angilosedation and a multimodal approach, the guidelines prioritize pain control over sedation to improve patient outcomes. Sedation should be minimized, and a patient's pain should be treated first before considering adding a sedative. All of the listed associations all recommend assessing pain frequently, and the Society of Critical Care of Medicine recommends assessing pain at least every 4 hours and as needed. The CPOT is one of the most reliable scales for assessing critically ill patients who cannot self-report. The American Society of Pain Management and Nursing also recommends using the CPOT in all ICU patients. The CPOT is scored between 0 and 8, with 8 being the most amount of pain and 0 being no pain. These are the two examples of the CPOT scale. As you can see, the only difference between them is whether a patient is intubated or not. If a patient is intubated, it takes into account compliance with the ventilator and if a patient is not intubated, this is replaced by vocalization. Either way, the scale ranges between 0 being no pain and 8 being a lot of pain. The SWOT analysis includes strengths, weaknesses, opportunity, and threats to a project. The strength of this project included support from the pulmonologist, critical care director, managers, and educators. Another strength was that the Society of Critical Care Medicine supports the use of the CPOT in intubated and sedated patients. The CPOT is a reliable and validated tool. The weaknesses associated with the project included a lack of confidence and a lack of experience in implementing a new project. The opportunity for it was to decrease pain, decrease the amount of sedation patients receive, improve patient outcomes, and reduce the length of time patients spend intubated. The most significant threat to this project was the ICU staff's resistance to change. The ICU is a specialized area of the hospital where critically ill patients receive advanced medical care. This unit is staffed by highly trained healthcare professionals who are prepared to treat patients requiring intense monitoring and support. These patients may need mechanical ventilation, sedation, or medications that need close observation due to the effects they can have on the body. The care provided within the ICU is more comprehensive than was typically available on a regular floor. A mechanical ventilator is a specialized machine used to help patients breathe when they cannot do so on their own. Patient ventilator dysynchrony, also known as patient asynchrony, occurs when there is a mismatch between a patient's respiratory efforts and the support provided by the ventilator. This mismatch can happen at any phase of the respiratory cycle, including the inspiration or expiration of a breath, and is not synchronized with the patient's own breathing. Such asynchrony can lead to increased patient discomfort, prolonged duration of mechanical ventilation, and risk of lung injury. Proper synchronization is crucial for maintaining a smooth and effective breath cycle. Prolonged intubation is when a patient is intubated for more than 7 days. Pain is an unpleasant and emotional sensory experience that is associated with either potential or actual tissue damage. And angilosedation refers to treating pain first and adding a sedative to the patient second. As discussed previously, the current guidelines for many organizations recommend treating and assessing pain first before adding sedation or adjusting a sedative. When sedation is required, light sedation is recommended to promote the least amount of time on the ventilator possible. Even though this is well documented, patients across the world remain intubated for longer than is necessary and are being oversedated, which can lead to prolonged intubation. When patients remain on a ventilator for more than 7 days, there is an increased risk of infection, tracheal injuries, barotrauma, skeletal muscle deconditioning. At the same time, delayed weaning is associated with increased morbidity, mortality, prolonged hospital stays, and the risk of discharging to a long-term care facility. This project aimed to standardize the use of the CPOT and evaluates its effectiveness in improving pain management, reducing sedation levels, and decreasing the length of time patients spend on ventilators. The PICO question guiding this project is, in patients on mechanical ventilators in the ICU, does standardizing the use of the CPOT compared to the current practice, which is no standardized tool, affect the number of days patients spend intubated over 6 weeks? And the clinical questions guiding this project are what is the benefit of treating pain first, and what effects do ventilators have on patients? This DNPQI project aimed to address the problems associated with prolonged intubations by standardizing the use of the CPOT when assessing intubated and sedated patients and treating pain first. They also aim to reduce the levels of sedation and promote a positive change in the ICU. Its potential advantages included enhancing patient outcomes, shortening the duration of intubation, and mitigating the risks associated with inadequate pain control, oversedation, and intubation. The overall goal of standardizing the use of the CPOT was to reduce the length of time patients spend on the ventilator, reduce their time in the ICU, improve their mobility, and allow them to participate in daily awakening and breathing trials, and reduce the likelihood of ventilator-associated complications. Watson's theory of human caring is vital for nurses, especially for intubated and sedated patients who cannot express their needs. Each patient is unique, with varying requirements for analgesics and sedatives based on their individual medical history and current conditions. This theory emphasizes that patients should not be viewed as mere objects. They deserve compassionate care and recognition of their individuality. Effective patient outcomes rely on a strong caregiver-patient relationships and collaboration among healthcare professionals through an interdisciplinary approach. In this DNP-QI project, integrating Watson's theory with teamwork from various disciplines aims to enhance care from intubated patients. This holistic approach acknowledges the necessity of tailored pharmacologic and non-pharmacologic interventions, including emotional support from family. Research indicates that approximately 71% of critically ill patients recalled experiencing pain during their ICU stay. Pain can lead to myocardial ischemia, restlessness, and ventilator dysynchrony. Unmitigated pain may result in tachycardia, increased oxygen consumption, excessive release of catecholamines, prolonged intubations, extended ICU stays, and augmented mortality. Patients endure pain during routine care procedures such as repositioning, suctioning, immobility, and the use of hospital equipment like monitoring devices and endotracheal tubes. Patients who are unable to communicate may exhibit signs of pain through hyperventilation, tachycardia, hypertension, diaphoresis, grimacing, and withdrawal. Vital sign alterations often accompany pain. However, according to the Society of Critical Care of Medicine, vital sign changes are unreliable indicators of pain in critically ill patients and should serve as cues to further assess for pain. The objective of pain management includes alleviating suffering, promoting recovery, facilitating early mobilization, and reducing hospital length of stay. A multimodal analgesic approach should be utilized when treating acute pain, as it can improve patient outcomes. The Society of Critical Care Anesthesiologists states that inadequate treatment of acute pain can contribute to a delayed patient's recovery. They recommend using morphine or fentanyl as a first-line agent in the ICU and a neuropathic pain medication such as gabapentin. They also recommend using multimodal adjunct medications to limit the amount of opioids patients receive. These medications include acetaminophen, clonidine, gabapentin, ketamine, and regional analgesia. When patients are lightly sedated, they can participate in early mobilization and interact with their family members and healthcare providers. They are also likely to do better with spontaneous breathing trials and spontaneous awakening trials, as their respiratory drive and mentation will not be suppressed by the sedation. All of these things can help mitigate a more rapid extubation. Endotracheal tubes can cause various negative effects, including laryngeal injuries that result from pressure and inflammation on the larynx and surrounding tissue. These injuries may lead to vocal cord ulceration, laryngeal edema, stenosis, dystonia, and vocal cord paralysis. Patients who remain intubated for more than 3 or 4 days are at higher risk of developing mucosal ulcerations and granulomas. Dysphagia also affects approximately 60% of patients who have been extubated, and about 50% of them also experience aspiration. Mechanical ventilation can have serious complications that are well documented in the medical community. Barotrauma is one complication that occurs when the alveoli rupture, which leads to the release of air and causes conditions such as a pneumothorax and subcutaneous emphysema. Up to 50% of patients who require medical ventilation can be affected by barotrauma. Additionally, bacteria can adhere to the endotracheal tube within hours of intubation, leading to infections such as pneumonia or sinusitis. Ventilator-associated pneumonia is a hospital-acquired infection that can occur after 48 hours of intubation and increases the risk of mortality. Furthermore, mechanical ventilation can cause diaphragm atrophy, leading to ventilator-induced diaphragmatic dysfunction. Studies have shown that up to 53% of mechanically ventilated patients experience this within the first 24 hours of intubation and can make extubation more difficult. Lung injury is a serious complication associated with mechanical ventilation, referred to as ventilator-induced lung injury. This complication represents a type of acute lung injury that impacts both the lung parenchyma and the airways, and it can be caused by or worsened by a mechanical ventilator. Alveoli injury results in various complications, including alveolar hemorrhage, increased permeability of the alveoli, both alveolar and interstitial edema, and a reduction of functional surfactant and alveolar collapse. These issues are similar to what is seen in acute respiratory distress syndrome. Ventilator-induced lung injury can also result in hypoxia, pulmonary edema, barotrauma, multi-organ function dysfunction, and a higher risk of mortality. Additionally, hypoxia may arise during mechanical ventilation due to bronchospasms, which can lead to arrhythmias, hypotension, cardiovascular collapse, hypercapnia, and death. There are also non-pulmonary related complications which have serious effects on multiple organ systems, such as hypotension, heart failure, venous thromboembolism, ulcerations, gut hypomotility, erosive esophagitis, diarrhea, decreased splenic perfusion, acute kidney injury, weakness, and disordered sleeping. Skeletal muscle can exceed 10% loss in the first week of ICU care and experience 1% muscle loss for each day a patient remains immobile. Those who have had a prolonged course of mechanical ventilation experience more respiratory weaknesses, which can lead to a difficult time being extubated, leading to prolonged ICU stays and are at higher risk of complications such as pneumonia and the need for a tracheostomy. It is estimated that up to 13% of patients who require intubation will need prolonged mechanical ventilation. Unfortunately, prolonged intubation has been linked to increased morbidity, mortality, and high hospital costs. Additionally, there are a number of infections that can arise from this, such as C. diff, bacterial pneumonia, urosepsis, and tracheobronchitis. Furthermore, renal failure, seizures, laryngeal edema, tracheal bleeding, pneumothorax, fluid overload, and ileus are just some other issues that can occur. In cases where patients cannot be successfully removed from a ventilator, a tracheostomy may become necessary. This typically occurs after 14 days of intubation. Subsequently, these patients are transferred to a long-term care facility where efforts to wean them are continued. Unfortunately, not all patients will be able to be taken off this life support and may end up spending the remainder of their lives in an LTAC. As a result, they are at higher risk of falls with injury, pressure ulcers, skin tears, adverse drug effects, and infections. This project is a quantitative project that evaluates how much time patients spend on a ventilator. Quality improvement projects are designed to implement an evidence-based intervention that has been shown to improve patient outcomes. In this study, I standardized the CPOT when assessing intubated patients' pain and assessed its effects and its impact on the length of intubation. The Plan, Do, Study, Act framework is a widely recognized and efficient model for quality improvement projects in healthcare. It was designed as a straightforward approach that offers a cyclic and rapid process that accommodates small sample sizes and short durations, which was appropriate for this project. Inclusion criteria for this project included anybody 18 years or older and who were intubated. The exclusion criteria were patients who were 17 years of age or younger, who were not intubated, and those who had a tracheotomy. The independent variable was the CPOT, and the dependent variable was the length of intubation. The first step toward standardizing the CPOT was to plan. This included working with the NTICU manager, IT, and a clinical nurse specialist to develop a way to run the most accurate reports. The NTICU manager was able to generate a report using Epic that included de-identified information about when the patients were intubated, when they were extubated, and their total length of intubation. The CNS was able to run a report that included all demographics for these patients. During this time, I created educational materials related to my project and the CPOT scale. 1 week prior to implementing the project, I was at the hospital every day, twice a day, to educate the staff one-on-one, and I've also posted a QR code throughout all 3 units and sent an educational email out about the project. During the do phase, the CPOT became a standard assessment tool to evaluate pain in intubated patients. This was charted every 4 hours as needed and before adjusting sedation. If a patient's CPOT score was elevated, nurses were encouraged to treat the patient's pain before increasing the sedation, and this project was ran over 6 weeks. To evaluate whether standardizing the CPOT influenced the length of intubation, this involved several steps. Initially, reports were gathered from Epic that documented the duration of intubation for 43 patients in the 6 weeks prior to implementation. Statistical analysis were conducted, including a descriptive statistics and non-parametric tests, due to the fact that the data did not follow a normal distribution, as confirmed by the Shapiro-Wilk test. The Mann-Whitney U test was used to compare the median length of intubation before and after the CPOT was standardized. A Spearman rank correlation was performed to explore the relationship between CPOT scores, length of intubation, and length of stay. The power analysis was conducted to assess if the study's ability to detect true effects given the sample size and observed outcomes. The age distribution of patients in the study revealed that the largest group was aged 60 to 69. The following was those who were between 70 to 79 years old, and the smallest representation was those who were 20 to 29. The other age groups were fairly evenly distributed, including a diverse range of age within the population. The mean age of participants was 60, the youngest patient was 21, and the oldest was 88. The 3 most common reasons for hospitalization were postoperative abdominal surgeries, traumas, and seizures, which each accounted for about 10.71% of total hospitalizations for this project. Respiratory failure, which included both acute and chronic forms, along with hypoxia, accounted for 9.52% of encounters. DKA, altered mental status, and shock each also accounted for about 4.76% of encounters. Diagnoses were categorized and combined when applicable to ensure a thorough analysis of all the clinical characteristics of the population. This demographic analysis provided a valuable insight into the diversity of the patient population and served as a critical foundation for guiding this quality improvement initiative. Table 1 compares the descriptive analysis for the length of intubation before and after standardizing the CPOT. The average length of intubation from 6 weeks before standardizing the CPOT and the average length of intubation after the 6 weeks after the project was run. The 6 weeks before the standardization of the CPOT, the average length of intubation was 4.51 days. After the CPOT was standardized, the average length of intubation decreased to 3.72 days. This indicated that the mean and median intubation length decreased after standardizing the CPOT. Table 2 compares the average CPOT scores before and after the CPOT was standardized. Prior to standardizing it, the CPOT score was 0.996, and after standardizing, the average was 1. The mean CPOT score increased, which could potentially reflect in improved pain assessments. The Shapiro-Wilk test was conducted to assess whether the length of intubation followed a normal distribution. The results indicated p-values greater than 0.05, suggesting that the data was not normally distributed. Consequently, a Mann-Whitney U-test was employed, validating the use of a non-parametric test instead of just a t-test. The Mann-Whitney U-test was utilized to compare the median length of intubation before and after standardizing the CPOT in intubated patients. This test was appropriate because the data was independent and the pre- and post-intervention groups consisted of different patients. In this analysis, the independent variable was the CPOT score, while the dependent variable was the length of intubation. The Mann-Whitney U test revealed the test statistic of U equaling 1053.5 and a p-value of 0.26. Since the p-value was greater than alpha, the project leader failed to reject the null hypothesis, indicating that there is no statistical significance in the intubation duration before and after the CPOT was standardized. The effects of the Mann-Whitney U test suggest that standardizing the CPOT did not lead to a statistically significant change in length of intubation. Although some trends were observed, they were not substantial enough to indicate a meaningful clinical impact given the sample size. The Spearman's rank correlation test was also used to identify relationships between variables. This non-parametric method is effective for measuring non-monotonic relationships, especially with data that is not normally distributed. The test evaluates the strengths and direction of the relationship between two continuous variables. Specifically, it was used to assess whether higher CPOT scores were associated with shorter intubation times and to determine if the length of intubation correlated with the length of stay. The first correlation that was examined was between the CPOT and the length of intubation. The coefficient for this pair was 0.0348 and the p-value was 0.825, indicating that this correlation was not significant. In contrast, though, the correlation between the length of intubation and the length of stay yielded a coefficient of 0.067 and a highly significant p-value substantially less than 0, with a significant p-value of 0.0000001. Power analysis was conducted to evaluate the study's ability to detect a true effect based on the sample size and observed effect size. The calculated power was 0.1613, which was significantly lower than the acceptable threshold of 0.8, indicating the study was underpowered and may not have detected a significant effect even if one existed. To achieve adequate power, approximately 365 patients per group would have been needed, but the sample size here was only 86. The alpha level was set at 0.05 and the effect size of 0.1613 suggested that any observed differences were minor and unlikely to be clinically significant. The margin of error in the length of intubation before and after the CPOT was calculated to be 1.17 days, indicating that the actual mean length of intubation was likely within range of the observed mean, further confirming that detecting differences was minimal. The bar graph displays individual patient data that compares the length of intubation before and after standardizing the CPOT for pain assessment. The blue bars represent the pre-intervention group, and the orange bars represent the post-intervention group. It suggests a trend towards reduced intubation periods after implementing and standardizing the CPOT. The box and whiskers plot illustrates the distribution of the intubation periods before and after standardizing. The mean duration of intubation decreased from 3 days before standardizing to 2 days afterwards. Additionally, the interquartile range was more narrow after the intervention, indicating less variability in intubation durations. While the maximum intubation duration remained at 16 days for both groups, the minimum duration decreased to 0 days in the post-intervention group. The higher median duration in the pre-intervention group suggests longer periods of intubation with several notable outliers indicating significant delays. In contrast, the lower median duration in the post-intervention group reflects a reduction in intubation length, although some patients still experience prolonged intubation. Despite a p-value of 0.259 indicating no statistical significant difference between the two groups, this box and whiskers plot does suggest a trend toward shorter intubations following standardizing the CPOT. Box plot compares the length of intubation across different diagnoses before and after standardizing the CPOT. The durations before are shown in yellow, and those after are displayed in orange. Each box in the plot represents the interquartile range with a black line inside denoting the median. The whiskers extend to the minimum and maximum values, excluding any outliers. This figure illustrates the change in intubation durations across various diagnoses following the standardization of the CPOT. The effects of the intervention varied by diagnosis. Patients with respiratory failure experienced the most significant reduction, with post-intervention intubation times decreasing to 75% of the pre-intervention values. This indicates an improvement in extubation practices for these patients. In contrast, patients who underwent abdominal surgeries and those who suffered from a trauma saw moderate reductions in intubation times, with median durations dropping to 50 and 40% of their pre-intervention values. Conversely, patients with seizures exhibited minimal changes, suggesting that the standardization of the CPOT had little effect on their duration of intubation. This bar graph compares the length of intubation and the average CPOT score before and after standardizing the CPOT. The blue bars represent the average length of intubation, which decreased, and the orange bars represent the average CPOT scores, which increased. It illustrates the trend of treating pain first, which was associated with a decrease in the length of intubation and an increase in CPOT scores. The data suggested a potential clinical benefit of treating pain first by reducing the amount of time patients spend intubated, but due to the small sample size and study limitations, the effects were not clinically significant. According to the PDIS guidelines, prioritizing pain management is crucial. Many intubated patients experience moderate to severe pain both at rest and during routine care. Severe pain can have detrimental impact on critically ill patients, potentially causing cardiac and respiratory instability, which may result in extended periods of intubation. Treating pain first should lead to a reduction of time spent intubated. The average length of intubation decreased from 4.51 days to 3.72 days, although a reduction in the Mann-Whitney U test showed no statistical significance. The average CPOT score for the pre-intervention was 0.996 and the post-intervention was 1.34. This increase suggested better pain detection, which could have led to more appropriate pain management in these patients. However, the Mann-Whitney U test for the CPOT score showed no statistically significant difference. These small effects indicated minimal measure impact of standardizing the CPOT. Even though statistical significance was not achieved, the trend suggests that identifying and treating pain first may have reduced the time patients spend intubated. There are several well-documented effects that ventilators have on patients, which include pulmonary complications, infections, acute kidney injury, delirium, and muscle atrophy. The pathophysiology impacts of mechanical ventilation can lead to prolonged hospitalizations due to its factors such as inflammation and immobility. Standardizing the CPOT led to a decrease in the average hospital stay from 12.31 days down to 10.92 days. A significant positive correlation was observed between the duration of intubation and the length of stay. These findings suggest that reducing intubation time may improve patient outcomes and contribute to shorter hospitalizations. The scatter plot illustrates the positive relationship between the length of intubation and length of stay. Each point represents an individual patient, and the red regression line indicated the overall trend, demonstrating that as the length of intubation increases, so does the length of stay. This relationship was statistically significant as Spearman's p was 0.667 and p was less than 0.001, suggesting that efforts to minimize the duration of intubation may have resulted in reduced time in the hospital. The descriptive analysis showed the reduction in length of intubation from 4.51 days to 30 to 3.72 days and an increased CPOT score. The Mann-Whitney U-test found no statistical significance between pre- and post-intervention groups. The effect size analysis confirmed a small group, which meant that standardizing the CPOT had minimal measurable impact on length of intubation. The confidence level showed vast uncertainty, which indicated the results may have been due to chance. The correlation tests between the CPOT and length of intubation and CPOT and length of stay were not statistically significant. However, the relationship between the duration of intubation and length of stay was statistically significant. Based on the results of this project, it is my recommendation that this project be adopted and become the new standard of care when assessing pain in intubated patients. Prior to standardizing the CPOT, the average length of intubation was 4.51 days, and after the average length of intubation was decreased to 3.72 days. Even though this DNP project is non-reproducible, it was limited to 2 individualized patient groups of patients. If the project leader were to attempt a similar project, future recommendations to improve it would have been to increase the sample size, improve education, and control external factors. A future project should increase the number of patients to improve a statistical power, which would consist of 365 patients per group for a total of 730 patients. The future project should also be conducted over a more extended period of time. Since this project was only conducted over 12 weeks, results may have been impacted by the difference in seasons. Ideally, this project leader would take 2 years to run the project. The first year would include all the pre-intervention patients, and the second year would include all the post-intervention patients. This would minimize the bias of respiratory illness trends. Finally, improved education about how, where, and when to document the CPOT should also be done. This should be done more continuously to address the nurses who start employment in the facility after the project begins, and throughout to ensure nurses continue to adhere to the project.